since we're the thing standing between you and your evening cocktail hour, I just wanted to say thank you for hanging in there. And this is a great way to end because there's a lot of content here that we've talked about that will be relevant to us. George Garro, I could let him introduce himself, but he and I met a few years back, and he's the CEO of a large, 47 federally qualified health centers all through Pennsylvania. I didn't think when we first met. It's going back a while, but I guess it was the Lehigh Valley, and I was going around the countryside looking at rural primary care places. So, and they're doing marvelous work. This is part presentation, part consultation. We actually want your advice, and just going to start off by just trying to go through our slide deck here. That was faculty disclosure. We had to have learning objectives. But we both have a strong interest in community health workers. Community health workers are not all that new, but what community health workers are doing relative to healthcare and being integrated into healthcare teams is a newer thing. And so that's what we want to talk a little bit about them. Is just as a reminder, they straddle the community and the clinic. They are a bridge for health and social services, but they also have relationships. This is sort of a quick summary of what they tend to do. They do a lot of motivational interviewing. They help with navigation. In fact, patient navigator and CHW are sometimes synonymous. It may be a community health worker who's doing that work. They do social risk factor screening, and they do a lot of advocacy as well as provide health education. So I want to talk to you a little bit about a case study. It has to do with George's practice, collection of practices, and a medical student who's here at the conference is going into family medicine. And we came up with this idea of going to the front line. I was trained to go to the Gemba, and if you really want to talk to people who are helping to delivering the care, talk to them. And so I think in these areas, mixed methods and qualitative research can be very, very effective. And so we chose to say, well, if we really want to know how well the CHWs were integrated, how long ago, maybe you talk just a minute or two about what made you integrate the CHWs into your practices.
Sure.
And what was the driver for that?
Yeah, we heard earlier about pivotal moments in our lives and our careers where everything changes, and the description about 9/11 just brought back all those memories of how the world changed overnight, right? And for me, COVID was obviously one of those situations. I never expected in my career as a physician that I would be dealing with a global public health emergency, right? And here we are in the midst of working from home and the lockdown and the struggle of connecting to our patients when a lot of our patients don't have cell phones. We care for a large Amish and plain people population in Pennsylvania. And I'm sitting at home thinking, how are we going to, recover from all of this? And we had unfortunately furloughed several hundred employees in our organization just because they couldn't come in, they couldn't work. And I thought of those two areas and thought, how can I use the resources of those folks that we furloughed to connect to those individuals who are now disconnected? And God bless the people that work with me, because I'll often come up to them and I'll say, what would it look like if, and I, virtually, and I said, what would it look like if we brought those people back from furlough and sent them out to help to connect to those individuals who are now disconnected? And that was really the beginning of my leaning into incorporating community health workers, peers in the community, as part of our mission to improve the health and improve access to care in our community.
Okay. So we took a Kurt Stange framework. Rebecca has mentioned him. And this is a great framework if you want to learn anything that's got multiple touch points, if you will. Okay, so we took the group of community health workers. There are about, what, 15?
We up to 19 now.
Yeah, and so we got 9 of them to volunteer to participate. We had a group of 5 and a group of 4. And what we did was we used questions in the focus group design to say, well, what's it like being a community health worker? What's questions about identity? And then we also wanted to know, since this was an integration, and there's lots of that integration that's gone well, and there's some place where it's gone terribly because they don't attend to the relationships or prepare the organization. You know, how'd it go, right? What do you think your team, who do you consider your team, right? What are the roles that you do? And the people that you serve, what are those stories? What's the content of the work? And then finally, in this external quadrant, the larger, what I'll call macro things. So organizationally, what's it like working at PHN? What are the issues that are important to you as a community health worker who wants to have a career path, wants to have other things that are important to you in the context of the organization? So we wanted to get at some of the sustainability questions that came up there. But this ways of knowing framework was described probably 20 years ago. It was actually stolen from another guy, Ken Wilber, who has a book on the lots of things. A Theory for Everything was his book. So this is just in a nutshell what we found is what community health workers love to do is work in relationship in a community setting, right? And building trust, and by doing that and having that base of trust, enough to then connect them to resources that can help. They like to problem solve, and they also feel that they can be effective at motivating people toward change. Now, some of that is by actually closing some of the gaps that they have. Right? And the other feedback we got, at least when we talked about team, is that, and this is one of the learnings, so there were lessons learned, and part of the whole project was to say, if I could do it again, what would I do? And one of the things that they said is when they got on the job, people were accepting to them, which is great, because PHN is a really healthy culture. There's been articles written about nurses and other disciplines where they kind of like, you can't do that. You know, if you can remember when nurse practitioners first came in with family physicians or for physicians in general. But they had to do a lot of educating on their own. And to their credit, they had the assertiveness skills to just invite themselves into team meetings and some of the other meetings of the group so that people knew what they want. One of the quotes really stuck with me is, they call me the social determinants lady. He says, I'm okay with that because at least they know what I do. And then they would start to send more referrals to them. So they also noticed when working with the Amish population that there wasn't good shared understanding across all the team members in terms of what their lives are really like, right? They use electricity, you know, many of them shun, not to use an Amish word, but you know, don't really enter into the healthcare system until they really are sick. And they also have, like many cultures do, their own methods for healing and for intervention. So there are clearly some implicit biases that one always has to work at when you're working with a very specific population. When they talked about their work, they distinguish themselves of what we do is different from what a nurse care manager does. It's different than a social worker does. And yet there was a level of respect. You know, some people call them mini social workers, or, you know, but the reality is this was what described it best. We're the boots on the ground. We're the ones in the mud. And that was from a quote from a community health worker who was working with a mother and 3 children who were living out of their car at the time. They said, you know, they're back there giving immunizations and doing screenings, and we're out here, we're in the boots on the ground, we're in the mud. So they also talked a little bit about issues of burnout. So in the beginning, pretty high caseloads. They were paid on an hourly basis, and that combo with that severity and not having an endpoint, you have to know when to close your case, was really causing a lot of emotional stress for some of the CHWs. To their credit, they were very proactive. The supervisor for the community health workers was herself a social worker. I think really understand their ethos, their identity, and was proactive before we could even get the data back to them, because we debriefed with the PHN leadership. They had already addressed just about every one of the lessons learned before we could get back to them. Now, we're not whizzes at qualitative data. It took us a year and change to get the themes done. But what they have done now is actually try to load level, and they have also changed to a salary model, so that if they have to stay late and address some issues, that there was some fairness into some of those aspects. And then they have also have mentorship that they've set up, both external to the organization, within the organization. So all the things that we would want, right, in terms of an emerging professional. Remember, these are folks who are typically high school graduates. Some of the group were second career folks, but a lot of them were looking to say, well, what is this all there is? I can't do this for 20 years. You know, is there something I might do? And then organization, what we identified is these two aspects of mentoring and compensation, developing professional associations, the same things that keep our juices flowing. So, so there were the sort of the distance. I don't know that. I ended up saying, well, geez, maybe we should do a little lit review and see what's been done. All right, there's not a ton out there, right? There's been a couple of systematic reviews during CMMI. There was a whole waft of trials of practices, and a couple of them, 13 organizations, actually had implemented CHWs in a variety of settings. And this looked through like a practice ecosystem lens, all right? And this is what they kind of found. And some of these are intuitive, like, yeah, define a role, communication, you know, motherhood, apple pie, and then readiness was a barrier, as well as sometimes tensions with some of the existing players. So the one thing I think we decided that probably would do differently is, hey, let's talk about what this might mean for people. Yeah, the right people in place, great leadership, and a good culture. And I think that, you know, from a standpoint, I think there's a lot of things that could have gone awry, but didn't. Now, there's even less literature around the rural context. Context, so important in what we're doing. And this was another systematic review with 26 studies, and a good chunk of them were pre and post or cohort studies, maybe not the strongest thing, but it was more descriptive. So about 30% they were integrated healthcare team. A lot of them did health education, so that's not the primary role that the HWs at PHN do. They do more of the health system navigation, but they will do patient education in a contextual manner while they're out visiting folks. And then who's the patient populations? I think, did you really select who you were going to have them see? I think it was really more of a geographic.
Yeah, we're geographically, we're large. We're in 17 counties across the state of Pennsylvania, largely rural, small communities. And so we really have the team spread out so that they can be within a certain geographic distance of the patient population that we're serving. Yeah.
So the other two things I think were important when we think about, you know, a future orientation is how do you know you're being successful? Right? And again, it's part of team-based care, but how do you tease out what they've brought, what's the new thing that they can bring? And this is what the systematic review showed, that some people are focusing on chronic illness, and so, okay, intermediate measures for that. Patient activation measure is actually a validated tool. It's licensed, it costs money to use it, founded by a couple of nurses. And then changes in the stage of change, if you're looking at Prochaska's motivational interviewing, and then show rates, because if they'll actually come in, if you can do something with them, and there are huge transportation issues facing those rural communities. And what's also interesting is, okay, a lot of this stuff gets started, but how many of these models will be here in 10 years? And this is, I think, the part that we would like to plug in and get some advice on. There are some people who have shown dramatic changes. Academic health center setting, Wharton Business School is your next door neighbor. You know, you have a lot of resources, but Shreya Kangovi, who's in Philadelphia, took a very sick population, reminded me a little of Jeff Brenner's work, in terms of, hey, if you take the sickest, then hopefully you have an opportunity to move the needle. And they had a model where they basically took people at hospital discharge and said, we have just a few goals here. Let's get you to the doctor for your follow-up appointment so we don't miss that connection. Let's focus on what goals you have that might be able to be achieved in, say, 6 weeks. And then we're going to really, or 6 months in some of the cases. And they just banged at it to try to see what would happen. And a lot of nice things happened because these folks were a complement to the medical team. It wasn't, let's get your diabetes under control. It was patient-centric and said, what's most important to you? Oh, I just had a joint replacement. I really want to get back to playing with the grandkids. Right? Very different than let's just make sure that you get to your PT sessions and so forth. So these, again, high-risk population, low turnover because they were very well managed. They had a big argument with the Department of Nursing, who were trying to keep them out. They founded their own institute. That was their answer to that. Lots of good. So we're looking at all these measures and thinking, okay, you're going to get a payer to pay for these, right? So they publish their data. I haven't been back there to visit them recently to know whether or not it's made a difference because a lot of the people they were serving are Medicaid, Medicare, and dual eligibles. So these are the problems we would like some advice on, and we've talked a lot about them. So yes, you need a measurement infrastructure. And I'm going to turn it over to George because I really think these are the questions of the moment in terms of saying, we've heard a lot about this earlier today and probably have answered some questions, getting started, but then also engaging whatever structures, whether they be payers, particularly in an FQHC setting. So I'm going to trade places with you.
Well, thank you, Bob. Thanks. And thank you, everybody, for hanging in there. It's been a great day. In full transparency, I am not a family medicine physician. I am internal medicine trained a long time ago. I went on to do a medical oncology fellowship at Vanderbilt University. I'm also boarded in hospice and palliative care. And curiously, when I was studying for my hospice and palliative care boards at a board review course, the first 3 days, the presenters bashed oncologists because you all know the joke, how to keep oncologists from giving chemotherapy, putting nails in the coffin so they can't get in. So, and the third day, I was sitting in the back of the room and I raised my hand and I said, excuse me, I'm an oncologist. And the entire room went and turned around. So and I'm from Western Pennsylvania, and even though I am not one of yuns, I may not be a family medicine provider, I am now. You had me at hello.
There's been a kindred spirit.
Yeah, a kindred spirit for a long time. And I work at the community health center because I really believe very deeply in the mission of improving health outcomes in our communities. If I was to show you a map of the county health rankings put out by the Robert Wood Johnson Foundation, there are 67 counties in Pennsylvania that are ranked every year. Philadelphia always comes in at number 67, obviously a large metropolitan area with their own health concerns. But if you look at the bottom quartile of health outcomes in the state of Pennsylvania, otherwise, those are the counties where I work. And I've been going to stakeholders in those counties and really asking them to think outside of the box. What is your talk this morning? Like I'm like so buzzed. Is that how do we improve health? We've got to move the needle. We have to think differently about what health means and how we're achieving it. And I will tell you that the community health workers in our organizations are the MVPs. They're the ones that are really making the difference. They're making the connections for those risk factors, for food insecurity, housing insecurity. And the one risk factor that I'm now going to call it, we used to call it social drivers of health, that has risen to be perhaps the most frequently reported when we screen our patients is loneliness and isolation. And these are the folks that go out there and spend time with people that are lonely and isolated and are helping them to feel part of a community again. So my questions for you, or I guess what I would really like to hear from the group, is how can we hardwire these types of services to be part of our care delivery and just make it standard. It's not new, it's not innovative, it's just what we do. And then the second important question is, obviously this has to be something that's sustainable. And I think for the models that I've heard today about direct patient care, direct primary care and advanced primary care, this is an easy way to bring somebody onto the care team, not going to cost a fortune, right, but can really make a big difference in keeping people healthy. In my setting, we're paid very differently, and I had some conversations with folks earlier. We're going to work on how FQHCs are paid, but our funding is under major attack. Health center funding is we get some appropriations from Congress. We won't talk about what that looks like, but also some of the revenue that we use to pay for our community health workers comes from our 340B savings. And even though we're using the 340B savings for the intent of the program, that program is under serious threat. And so, as the CEO of my organization, I'm looking at the risk of having to lay off my community health workers. And I'll tell you right now, I'm going to fight like hell before I let that happen. But, okay, so anybody have any advice, comments?
What's the size
where to
of
go
the
from here? I'm sorry?
For the CHWs, could you give us a sense of how much do they make, and what's the size of the budget of the whole org, and what's their part of the budget?
Yeah, at our organization, we've made a commitment that every one of our employees, from the entry-level community health workers, front office workers up, will earn a living wage. They're paid, I think, fairly. None of them will have to have two jobs to be able to care for their family. Relative to the budget of this, relative to the budget of the organization, I don't have that number in my fingertips. I'm sorry. Yeah.
Are you compensated on total cost of care reductions at all?
No.
Can you negotiate that? Because they would save you a fortune.
Right? Yeah. They're very good. Yeah, very excellent.
I just finished my training at UPenn 2 years ago, and I'm not sure if you've connected with them, University of Pennsylvania in Philadelphia, but they have an excellent community care worker network that mainly is dealing with the discharged patients from the hospitals, which I know you mentioned. I'm not sure on the specifics of what they're doing now after COVID, but I do know that our patients benefited a lot from their services. So I don't know if that's a collab you want to.
Yeah, actually all of the Medicare and Medicaid MCOs were part of the, sort of advanced PCMH care. And so we do get some additional monies as part of that program, but relative to the cost of paying the salary of these individuals, it's really pennies on the dollar there. Yes?
So we're in a relatively similar situation. I'm at the Safety Net Hospital in Northeast Ohio. We had an erosion with 340B and so forth. So very similar struggles. We've had community health workers. They started off in our school health program. And we have an institute called the Institute for Hope that is really meant to address social determinants of health, and that's where our community health workers have been embedded. So we measure the improvement in the social determinants of health surveys over time by having the community health workers, they've been expanded to a few other areas, but that's one thing, and now we're working with insurers to say, here's what they're helping to improve, which hopefully will then get to some of the other outcomes that, that Rebecca mentioned that we measured that aren't as meaningful, but people will pay for. So that's what we're leveraging with our Medicaid payers to say, we're making a difference here, and we're going to come with an ask for new funds.
That's great. Well, if this were the Oscars, the orchestra is starting to play, so I don't want to go on. But I do have two comments that I want to make just before we conclude. Our organization cares for a lot of communities demographically that's a little bit older. We have, relative to other FQHCs, we have a high Medicare population. And in such, all of our primary care sites are now accredited by the IHI for age-friendly care. And we leaned in heavily to a model of caring for older adults called the 4 M's, if you're not familiar with it. But one of the M's is what matters. And across our primary care practices, we've changed asking the chief complaint, what's the matter? So the first question when patients come in is, what matters today, right? And I was shocked. None of them said, I want to know what my A1C is. They want to know where my next meal is coming from, or where am I going to sleep tonight. And this is where the MVPs come in. And the second piece, somebody earlier had mentioned about the unknown, the people that are out in the community that aren't connected to care. And so we've actually created a second branch of our team that we're calling community ambassadors. So they're going out and doing instantaneous community needs assessments. What's missing? What are the gaps? And how can we connect you to care? If it's with the FQHC, great. If it's sending you to another organization, great. But how can we connect you to care? So with that, I'll stop.
Thank you very much.
Sure.